Good morning, everyone, and welcome to this week's Department of Medicine Grand Rounds. I'm Dana Bowen, one of the chief residents here at University Hospital. Before we get started, just a few housekeeping tips. If everyone can please keep your mics and your videos off during the presentation, except for the presenters. Also, we ask that you hold your questions and comments till the end if there's time. And lastly, the CME information will be displayed at points during the presentation. Today, we recognize World TB Day with the 15th annual Dr. Reynard McDonald Lecture. Before I introduce our speaker for today, Dr. Alfred Lardiswall, who currently serves as the Executive Director of the Global Tuberculosis Institute, will start with a brief history of our special lecture today. Thank you, Dr. Lardiswall.
Morning, Dana, and good morning, everyone. Welcome to the Reynard McDonald Lecture. This is the 15th year we are holding this, and we do this in commemoration of World TB Day, which is March 24th, as well as to remember a favorite faculty member of the New Jersey Medical School, Dr. Ray McDonald. So, next slide, please. The World TB Day is really the day that Robert Koch, the father of modern bacteriology, discovered the cause of phthisis and the so-called White Plague, something that eluded humanity for centuries. And this was important because it meant that perhaps it'll finally be controlled and cured. This was the hope in 1882. And what you see here is the journal article that was printed in Berlin just a month after the discovery. Next slide. Thanks, Dana. So for World TB Day, various agencies, including the World Health Organization, the CDC, as well as medical societies like the ATS, IDSA, and the International Union Against TB and Lung Diseases, along with stakeholders working against TB elimination worldwide, commemorate World TB Day on this date to call the attention about the impact of TB and the ongoing global epidemic, which as of the last count in 2020, killed 1.5 million individuals. That's about a little more than 4,000 individuals a day. This is for a disease that really is treatable and preventable. For 2022, we are commemorating the 140th anniversary of the discovery of the cause of TB, and we still are dealing with this ongoing global epidemic. Today, we also remember Dr. Reynard McDonald, who was a faculty here at the New Jersey Medical School from 1974 until his retirement in 2014. He was a pulmonologist and the medical director for the Lattimore practice throughout his career here at the medical school. He is well loved. He was a great TB clinician, but most importantly, he was an advocate for patients. He embodied what we today call person-centered care long before it was even fashionable. And for that, we take this time to remember those virtues that Dr. McDonald had shared with us through his years here. As a matter of fact, this this annual talk is sponsored by a grateful patient Dr. McDonald once took care of, to focus on the humanism of this beloved Dr. McDonald. So for today, our speaker for the McDonald Lecture is Dr. Maunank Shah, and he will speak about the innovations today along the spectrum of TB care. I'll pass it on to you, Dana, to introduce Dr. Shah.
Thank you, Dr. Lardiswall. Today, our guest, Dr. Shah, who is joining us from Johns Hopkins, will give his talk on tuberculosis care. He's currently the medical director for the Baltimore City Tuberculosis Program and associate professor in the Division of Infectious Diseases at Johns Hopkins. His academic interests focused on innovative technologies to improve medical education, public health, clinical care, and patient outcomes with a focus on infectious diseases, including TB and HIV. Dr. Shah also enjoys exploring and assessing new e-learning tools. This has led to his collaboration with the CDC to use special software to build interactive educational decision support tools to aid learners in latent TB care. Dr. Shah has also completed projects to evaluate new TB diagnostic technologies and assess cost effectiveness of emerging strategies for TB care in Baltimore and in the global arena. Dr. Shah's work is renowned in many circles as he is the recipient of many prestigious awards, including the Excellence in Advising Award from the Johns Hopkins Center for Global Health and the Robert Koch Award for TB Researcher of the Year. Without further ado, Dr. Shah, thank you for joining us today to give your talk.
Dana and Al, thank you so much for the opportunity to speak with you all today. Let me start sharing my slides. Can you all see my slides okay?
Yes.
Terrific. So thank you again for this opportunity to speak today. It's a real honor to be able to share with you a discussion on innovation. And that's really going to be the core theme that unites some of the disparate topics that I'm going to cover today. And we're going to talk about innovation along the spectrum of TB care. And that ranges from the patient to physicians as well as populations. For housekeeping, here is the CME information for the day. Here are my disclosures. And our objectives today are going to be to cover a variety of topics ranging from diagnosis to treatment to medical education and patient decision support. But the unifying central theme that I really want to focus on is that of innovation. As Dr. Larzabal mentioned, tuberculosis has been with us for centuries, and 150 years ago, when the bacterium was discovered, there was a real sense of hope and optimism that we might be on our way to controlling this disease. But in many ways, the TB field has really been quite slow to, despite the fact that this particular disease has led to a number of important discoveries, ranging from some of the first randomized clinical trials of new therapeutics to the discovery of various antimicrobials. But particularly in the last 20 to 30 years, I would sort of suggest that there is a need to continue to innovate. And I paste here the definition of innovation from the Webster's Dictionary. And I use that term quite broadly, just to represent new ideas, new methods, new strategies for approaching care in an effort to deliver much more patient-centered, in an effort to deliver patient-centered care. I'm going to cover a variety of different topics. And for that purpose, I'm going to use this general schematic just to orient us to where we are in the spectrum of innovation in terms of the target audience. And I use that term audience relatively loosely. So I'll discuss changes and new approaches to improving care for patients, but also for the practice of medicine by physicians and how we can use new tools to inform our policies that affect entire populations. I think that given that we're commemorating World TB Day, it's important to recognize that TB remains a leading cause of morbidity and mortality globally. While we don't always think of it as being front and center in the United States, in 2014, TB surpassed HIV as the leading infectious disease cause of death worldwide. Of course, that was overtaken in more recent years by COVID, but I think it's worth recognizing that there are nearly 1.5 million TB-related deaths annually, and that it continues to be the source of quite a bit of economic cost, as well as socioeconomic implications, as well as, of course, its impact on actual patient care, morbidity, and mortality. To start our journey in terms of discussing innovation, I want to start with this general schematic at the focus on active TB disease and a focus on TB diagnostics. I start here in part because this is where I started my own journey as a TB clinician and researcher nearly 15 years ago as an infectious disease fellow. And I think as was obvious to many at that time, our existing diagnostics were a major source of why we had not yet been able to control this disease worldwide. We continued to rely globally on technologies such as smear microscopy, an approach that was almost 150 years old and undertaken by Robert Koch in terms of diagnosis of TB disease. Our reference standard globally continues to be mycobacterial culture, which of course has a number of limitations, including being resource intensive and very slow. And so, starting as a fellow, I really started focusing on whether there are new approaches to TB diagnostics. And I want to share some of the work that we did over the last many years. To frame that discussion, I'll start with a case that presented in Baltimore a few years ago. There was a 66-year-old Scandinavian sailor who had been previously living primarily in Thailand and working on a variety of cargo ships, who was admitted from the port of Baltimore with several weeks of fever, weight loss, and a non-productive cough. He was febrile, hypoxic, tachycardic. He was noted on admission to have a positive test for HIV infection, a low CD4 count, and a high viral load. And a CT scan is shown here, which showed diffuse ground glass opacities. I think this case nicely highlights a number of the challenges we face in trying to make prompt diagnoses of tuberculosis. The first tests that are usually done when people are admitted to the hospital is smear microscopy. But I think it's worth acknowledging that new point-of-care sputum tests are desperately needed to replace this approach. In field conditions, smear microscopy has relatively low sensitivity, and to many people's surprise, individuals with advanced immunosuppression have yet lower sensitivity when relying on just direct microscopy from sputum specimens. Of course, this approach is also not specific to M. tuberculosis. I think many people may be familiar with the many different molecular approaches that have been emerging over the last decade, many of which were pioneered at the New Jersey Medical School, including much of the seminal work that went into the development of assays such as the Gene Xpert platform. Currently, the CDC recommends using nucleic acid amplification testing as one of the first tests to diagnose TB more rapidly. Nucleic acid amplification tests are much more sensitive than smear microscopy and pick up another 50 to 70% of individuals that are smear negative but culture positive. We could do a whole talk on different molecular technologies, but what I wanted to discuss with you all today and share is a slightly different set of approaches that people may be a little bit less familiar with. Coming back to this case and the reason why alternatives continue to be needed, despite advancements in molecular technologies, is highlighted here. This person had an extensive workup. His bacterial cultures in blood, sputum, urine were all negative. He had urine histoplasma testing that was done and serum crypto testing that was done that was all negative. He had a bronchoscopy, and this was smear negative. It was also Gene Xpert MTB RIF or molecular nucleic acid amplification testing was also negative. And I think it's at this point that we should always recognize that the limitations of our current diagnostic approaches for tuberculosis, and the reason why we need innovation and new approaches to rapidly diagnose TB. Namely, that despite these advancements, negative results still do not exclude TB disease. In this person's case, mycobacterial blood cultures continue to be pending. So I want to tell you about a novel non-sputum based set of tests that perhaps people may be less familiar with. This is work that I started on almost 15 years ago, and that involves a antigen that is found in mycobacterial cell walls known as Lipoarabinomannan. One of the things that was discovered now some time ago is that this particular antigen is detectable in patients with active disease and concentrates in the urine. Interestingly, this makes it detection of urine lipoarabinomannan an approach that is one of the first non-site specific ways that we might be able to actually diagnose TB. I'll show you a little bit more work, but some of the early studies identified something that was a little bit peculiar. That is that the sensitivity of this approach was very poor in HIV negative patients. For this reason and others, this approach was in some ways shelved for quite a while until there was sort of the identification that its sensitivity actually was quite a bit higher, particularly in immunosuppressed patients with severe disease. Now, I'm going to summarize what ended up being a decade of work in just a matter of a few lines and slides, but just to say that this approach went through a number of different hands. It changed companies several times, but now is available in a rapid point of care format with the results available in less than 20 minutes. Some particular characteristics of urine LAM testing are that the amount of antigen that ends up showing up in the urine is really proportional to the amount of disease in the body. So what that ends up meaning is that when you have isolated pulmonary disease or isolated extrapulmonary disease, there tends to be relatively little LAM antigen in the urine, and the sensitivity is relatively low. On the other hand, when there's mycobacteremia, as is often the case in patients that are immunosuppressed, the sensitivity starts to really rise. We also ended up showing now several years ago that the sensitivity is proportional. It's almost a dose relationship, an inverse dose relationship, such that the sensitivity increases as the CD4 count decreases. Another interesting finding was that identification of this antigen in the urine also gave information about the disease severity. This is a busy slide, and the text in the table is not particularly important to follow, but the key take-home point is at the top. And that is that within the context of these many different diagnostic accuracy studies that were being conducted, where the test was not being used for actual clinical care, but was being studied to determine its sensitivity and specificity, another very peculiar finding became very evident, which is that if you are urine LAM positive, whether you got treated or not, there appeared to be an increase in mortality, such that a number of studies suggested that urine LAM positivity correlated with a TB mortality of 20 to 50% or more. What I want to also bring up is that the journey that this new technology in this process of innovation sort of followed, which is to say that it was really kind of somewhat dismissed for quite a number of years as a very poor and suboptimal test. And that's not surprising. When you look at the net urine LAM sensitivity, it's only around 30 to 40%. And many people, including policymakers and guideline developers, largely dismissed this and said, well, why would we use this test when at the same time there were all these new molecular tests that were emerging that looked very promising, such as including the gene Xpert. One of the things we ended up showing in a systematic review for the WHO's policy development group was that there actually appeared to be additive benefit. Despite having relatively poor sensitivity, what we discovered was that adding this test to our existing armamentarium of molecular technologies actually improved diagnostic sensitivity and started to approach that of mycobacterial culture, and did so in a really rapid fashion. Two other very large randomized trials then were undertaken by two different groups, all in sub-Saharan Africa, which looked at what happens to patient outcomes if you just give people access to this test or not. And perhaps to many people's surprise, what was found was that introduction of urine LAM testing into the diagnostic algorithm in hospitalized patients ended up reducing mortality. And this was somewhat of a surprise because similar findings were not shown in other studies introducing more sensitive technologies, including molecular technologies. And it just highlights this idea that using this alternative approach that may allow for identification of individuals who would otherwise have gone missed in their TB diagnosis and gone on to have poor patient outcomes. Based on all of this data, there was a WHO guideline development group that met in 2019, which eventually ended up recommending that urine LAM testing be included as part of the diagnostic approach to diagnosing TB in HIV-infected individuals. But as a talk about innovation, I want to highlight that innovation requires advocacy as well. Despite being able to show that this relatively cheap, fast test could actually save lives, its uptake globally has been very, very poor. It's not, in fact, available in the United States and in a number of countries. This has led to a number of groups that have gone on to really try to advocate for this. There was a New York Times article, there's been demonstrations about this at various conferences, and this is just a headline from a policy statement that was released by a number of HIV and TB activist groups with the catchphrase "we're pissed," alluding to it's sort of a play on words since this is a urine-based point of care test. All of this came together to eventually inform the eventual WHO's policy guidance. And now it is, in fact, incorporated into global guidance that this particular new approach to TB diagnosis be considered for most patients with living with HIV. Part of why this why it was so hard to get this test into the diagnostic approach was that it's the first time that the international community had to wrestle with the idea of a niche test. Meaning this is not a test that replaces smear microscopy. It's not a test that replaces molecular technologies, but is really a test that needs to be used in conjunction with other assays. And our policy development processes are not really set up to evaluate tests in combination in this way. It's also the first non-site specific test, which means that it was actually quite hard to develop the evidence base for its diagnostic accuracy, because there are challenges with trying to understand what the reference standard should be when you have a person with urine LAM positivity, but negativity by, for example, sputum NAT testing. Nonetheless, this has made its way into international guidance and has opened the door for ongoing innovation. And some of that ongoing innovation was published just 2 years ago in the form of a next generation Lipoarabinomannan assay. This is work done in conjunction with FIND, which is a public-private partnership in Geneva, and a new generation assay, which is yet more sensitive by almost 30% compared to the earlier generation test, such that these new generation LAM assays may in fact offer an opportunity for point of care diagnostic testing that is non-site specific, which starts to approach the diagnostic accuracy of molecular techniques from other body specimen types. There have been more than 10 other studies now that have gone on to study this second generation assay, and a WHO policy guideline group is scheduled to convene later this year. And I will just say that several other companies have now taken on LAM assay development to try to explore this new approach to rapid diagnostics. So just coming back to our case, this person's urine LAM test was in fact positive. I'll say it's not commercially available in the US, but because of our work on the research setting, we happen to have some of these tests lying around. So this was a research use only assay, not necessarily for clinical usage, but nonetheless it was positive, which gave us, which was quite important in this person's case, which I'll show you why in just a moment. His cultures did in fact confirm the diagnosis several weeks later, but we already had a strong suspicion for TB on the basis of the urinary LAM positivity. Part of why this was important to identify and why one can start to see the need for rapid diagnostics is that this patient also had a number of other concurrent diagnoses. He was positive for pneumocystis, which probably explains that ground glass opacities in his CT scans. He also had Kaposi sarcoma simultaneously. And I will say that his initial treatment course, which targeted PJP, did not lead to significant clinical improvement. And it wasn't until he started on TB therapy that his clinical course started to improve. I wanted to shift gears slightly, however, to now talk a little bit about how we make treatment decisions and how we support physicians in making optimal treatment decisions as well. And I think this person's case really highlights a lot of the complexities of delivering precision patient-centered care in 2020. As many people probably know, the optimal treatment of a person with TB who is also living with HIV also includes the initiation of HIV or antiretroviral therapy. But there are many different drug interactions that also have to be considered. First-line drugs, many of which cannot be actually used when you're treating with erythromycin, and those that can be used require drug interactions. Other nucleoside backbones have conflicting data on their usage, and actually guidelines conflict in terms of which NRTIs can be used with various TB therapies. And I'll just say, and I'm going to deviate from TB care to talking a little bit about innovation in HIV just for a moment, and then we'll tie it back to TB. But I just want to say that ultimately, even after an effective diagnosis, we need to also have ways to support physicians to make optimal treatment decisions. This was particularly evident in my own sort of clinical training and in my own development as a clinician. As my career sort of started moving towards TB therapy, I found that I myself would, despite being infectious disease trained, having worked in HIV clinics for a long period of time, was finding that trying to make optimal HIV treatment decisions was becoming increasingly complex. The current treatment guidelines are over 200 pages long, and they advocate a patient-centered, individualized treatment decision because we now have so many different treatment options that are available. And I will hope that you will take what I'm about to sort of outline as a model for how we might approach improving physician decision-making across many different diseases. In this case, HIV is sort of a model system, which is just to say that in 2022, I think we can all agree that the pace of scientific discovery has increased to the point where it is challenging, even for clinical experts, to always be able to synthesize all the many different variables that need to go into optimal decision making. So about 5 or 6 years ago, we decided to try to approach this problem in a very systematic way using something called multi-criteria decision analysis. For those of you that are not familiar with MCDA, it's a branch of decision theory which covers decisions that have multiple objectives. That's not to say that they don't have multiple variables that go into the decision. It's acknowledging that the outcome of interest that we are actually trying to optimize have multiple dimensions. In the case of HIV, just to keep it really simple, that could include not just trying to think about which is the most quote unquote effective treatment, but also which treatment is going to have the least side effects, the lowest pill burden, which is most likely to allow a patient to be adherent, which has the least drug interactions. These are all outcomes that need to be optimized. And what we found is that there's not a clear way to help clinicians to weigh these different dimensions of different regimen outcomes. We therefore decided to map the decision-making pathway of expert clinicians and developed a multi-attribute utility function, essentially breaking down this decision-making problem into its core components and then synthesizing it into what we call a weighted score. I'm not going to go into the details or the mechanics of this, but just want to highlight how this might play out. We eventually constructed a very simple web-based user interface that allows input of these different considerations. For this patient's case, as an example, you can enter in the person's viral load, their CD4 count, all of which impact which ART regimens are considered the most effective, but also it allows you to input the different treatment regimens related to TB that the patient was on. The system then evaluates all 3,000 to 4,000 different technical permutations that are available of treatment choices. So there are about 30 different HIV drugs that can be used in different combinations, and it weighs all of this together. It also will synthesize dosing changes, summarizes the treatment, the number of pills, and incorporates the idea of delivering educational content simultaneously. You can click on any one of these treatment options and see a summary of food effects, the changes in dosing. So in this case, it's highlighting that the regimen Triamec, which is dolutegravir, abacavir, and 3-TC, actually has to be changed from once a day to twice a day due to the rifampin drug interaction. And it integrates with an entire pharmacologic database that is actually maintained by the University of Liverpool, and it allows you to see detailed pharmacologic data as well. What I'm not showing you here is that it also summarizes every clinical trial related to that particular treatment option and provides a number of other annotated explanations for the decision-making approach that led to that particular weighted score. Importantly, of course, however, is to try to understand, can this kind of approach actually improve patient care? So we decided to test this in a randomized trial where we gave medical students and residents with relatively little HIV training, we gave them access to this tool, or we gave them the actual current HIV treatment guidelines along with a short 5-minute video tutorial on how to navigate those guidelines. We then gave them 10 clinical cases of varying complexity. And we gave those same 10 cases to world experts in HIV care at Harvard, Hopkins, and UCSF. And we looked at how often did medical students and residents with relatively little training make the same decisions as leading experts. And what we found is that when they were given the guidelines by themselves, they only made appropriate treatment decisions about 40% of the time. On the other hand, when they were given this tool, which is called HIV Assist, they made correct decisions 90% of the time. And this was particularly evident when you started getting into increasing case complexity. In ART naive, very simple cases, individuals getting the guidelines made the correct decision about 75% of the time, but you can see 100% of the time if they were given this interactive tool. But when you got to complex cases where the patient was ART experienced, had drug resistance, things like that, the guidelines allowed the residents and trainees the ability to make the correct decision 0% of the time, whereas they were able to make correct decisions almost 100% of the time when they were given this kind of tool. And I think this just speaks to the fact that we need to think about innovation to allow for precision care to be delivered and to democratize medical knowledge. This shouldn't be the case that you have to go to an expert to be able to get expert level care. We can make usage of ideas like decision support and technology to help enable clinicians to make better and more informed treatment decisions in order to optimize patient outcomes. Now, I want to kind of come back to the patients now as we talk about those treatments. In this patient's case and in many others, eventually a treatment decision is made. But as we all know, for complex diseases, including tuberculosis, the treatment only leads to positive outcomes when we can actually support patients in those treatment regimens. And people, I think, are very familiar with the idea and concept of directly observed therapy, which has been put forth as a mainstay and backbone of TB-related treatment and care for the last several decades. But I want to just think about that approach a little bit more critically by sharing two additional case examples. Here we have another case, this is from several years ago, of a 44-year-old who was newly diagnosed with both TB and HIV in the hospital. She'd been very compliant, she was very understanding of the diagnoses, and was actually improving and doing very well. And once she was coming out of respiratory isolation, and this was her chest x-ray, sort of a classic right upper lobe infiltrate, it was explained to her that she needed to have therapy through the health department with directly observed therapy. At this point, she started voicing a number of concerns because she indicated that she felt that this was going to stigmatize her amongst her family at the house, who she had not disclosed in particular her HIV status to. And she was very worried about accidental disclosure and the stigma associated with having to have a nurse come to her home when she felt she was feeling very well. She felt she had very good insight into her disease and had no reason, and had offered no reason for anyone to think she could not take her medications on her own. This kind of scenario plays out not infrequently. Here I show you another case example that was actually somewhat more recent, of a 24-year-old from South Asia who was starting surgical residency, who was noted on employment screening to have a positive T-spot. She was completely asymptomatic, but had chest x-ray and then subsequently chest CT imaging with a reticulonodular infiltrate that was positive for tuberculosis by gene Xpert as well as by culture. She very much wanted to be treated, understood the disease, had good insight into this, but noted that she did not feel she could comply with DOT because she said this was going to be a real barrier during her surgical residency, particularly having to break off from rounds or from surgeries, and was very worried once again about stigma. And I think that in 2022, we have an increased appreciation for the amount of stigma that is in fact associated with tuberculosis, not just in the United States, but in particular in other parts of the world. And we need to actually be cognizant of how our treatment approaches might actually be playing into creating barriers for TB treatment and care, or worsening some of those additional aspects of care. And this is why I go back to, again, this idea of needing to optimize not just clinical effectiveness, but also many other dimensions of patient-centered care. I also want to just note a slight change that people may not think about very often, but which actually plays out in a number of ways internationally. And that is that in 2016 and 2017, both the US and international guidelines really moved away from the idea of intermittent dosing strategies, which were actually easier to implement with directly observed therapy. And they really shifted towards daily treatment. And this really raised a number of questions. And I had patients asking me this as well sometimes, which is to say that DOT was typically offered 5 days a week. And so they would ask, why do you trust me to take my medications on weekends and on President's Day and Columbus Day, but you don't trust me to take it on March 8th? And it really set up a really confusing dynamic for patients. And it made me really think quite a bit more granularly about what we're trying to achieve. And what I want to suggest is that we need new ways of thinking about adherence monitoring and adherence support. And this is, I think, also an aspect of innovation, that we have to be willing to think outside the box and outside of how we're usually comfortable. And I actually really like the way international guidelines are worded, going back now more than 5 years, which is that they break up the idea of adherence interventions and monitoring. So in other words, we need to start to think very concretely about what we're trying to achieve and why. There are very good reasons, I would say, why we need to monitor and document treatment for an airborne infectious disease. For things like directly observed therapy allow verification of treatment, and there are reasons that could be important. We know that non-adherence can lead to drug resistance, it can lead to poor patient outcomes, so there is a component of wanting and needing to verify treatment. There's also a recognition that we don't have biomarkers for cure, which is why the definition of treatment completion and success is actually based on completing a certain number of doses. So these are reasons why we might want to actually monitor or administration. But I want to distinguish that from the idea of DOT or any strategy actually supporting adherence. There's nothing about being watched that necessarily makes a person more compliant or adherent to their treatment. And these are just direct quotes from the international guidance, which gives a little bit more of a concrete idea of what it is, what component actually support adherence. And they recognize that this really needs to be patient-centered. Each patient needs something different. For some patients, having a nurse visit them on a daily basis, offering psychological support, nursing support, is a real boon. But for others, this can actually increase psychological and mental health stressors. It can also create barriers, especially when patients are asked to, for example, come to clinic for their directly observed therapy. There are other forms of adherence support as well that need to be considered: food incentives, financial incentives, and other ways to support patients as well, which really need to be tailored based on specific adherence barriers. Consequently, international guidance really kind of distinguishes this, I think, in ways that are a little bit more detailed than the current set of US guidance. While the US guidance still suggests using DOT rather than self-administered therapy, the international guidance goes on to advocate a much more patient-centered approach, suggesting that first, if you're going to do DOT, it should be community or home-based rather than facility-based, recognizing that particularly in resource-limiting settings, asking a patient to come oftentimes many miles to the clinic just to be watched is actually a barrier to treatment, not necessarily a benefit. It also acknowledges that technologies such as video observed therapy may be used to replace DOT. And this goes into the next aspect of my own sort of career development. as I became medical director at the Baltimore City Health Department, these kinds of stories where DOT was a barrier became much more evident over the years. And so we ended up eventually developing a video-based technology platform. And now there are many. And so the specific platform is not particularly of note, but just the idea and the concept is that we can actually use a smartphone to record people's ingestion of video and transport it to a or to a portal that then healthcare workers can review on their own time. This can be done live, meaning sort of the idea of being something similar to FaceTime or Skype, but it can also be done asynchronously, meaning a person can take the medications at midnight, which they often do, because that's their patient preference, and then allow the healthcare worker to watch the video at a different time. By using these technologies, you can actually do a number of other things as well, including, for example, collecting side effect and clinical outcome information on a daily basis, so that we can actually monitor how long did it, for example, a cough occur, and get much more documented documentation of whether or not there are side effects. These platforms available as an example in multiple languages, and you can also do a number of other things, including push educational content to patients. Of course, ultimately, we want to know whether this kind of thing is actually effective. And this has been borne out in several randomized trials now. And this is actually recently published data from New York, which showed that electronic DOT was non-inferior to in-person DOT. I will just say that the caveat to this study is that this only looked at Monday to Friday doses, which I thought was a little bit of a peculiar endpoint of interest, because this is not really treatment adherence. This is looking at how often do you verify about 70% of actual treatment doses, which is just Monday to Friday doses, and you do pretty well. A similar study from the UK showed something very similar, and I like this graphic. Each dot represents an observed event, and the top is whether you had in-person DOT, and the bottom is if you had video DOT, and you can just see that you do a lot better with video observed therapy. And we've seen this play out in pragmatic settings as well. We've done studies of this in California, for example, at a large urban clinic in Oakland. And what we showed was that video DOT, and this is now under non-study settings, just real world implementation, that when we just once the technology was available to the clinics, they actually used it 60% of the time, which was quite interesting at how fast this uptake was. And what they found was that they were able to document a greater proportion of prescribed doses than in-person DOT. But I'll just note that these numbers might seem a little bit low to you. You say that, oh, we're doing DOT because we want to verify therapy, and yet we're actually only verifying about 50 to 70%. And in this case, even with video DOT. And in this case, this was because of how one implemented this new technology. Again, gets into the idea of just having innovation is not good enough. It also comes down to how we actually put it into place. In this case, in order to try to harmonize with their in-person DOT strategy, they had told their patients only to videotape themselves Monday to Friday, and that weekends and holidays could be self-administered, which was kind of an interesting way in which DOT and video DOT was implemented, because they had the ability to actually observe and document 100% of therapy. We've done qualitative data analysis as well, where we've interviewed patients, and we've also done cost analyses of these. Initially, people were very concerned, for example, about about privacy. Whenever we say technology, we often think about data privacy, but I'll just note some of the quotes from the patients, where they said things like, having someone come to your house driving in that Department of Health vehicle, coming in, well, the whole neighborhood's going to look and start asking questions. And then they said, with video DOT, we can control the setting we are in. It's in your own hands. You just avoid taking videos in places where you can be viewed by others. We have control. So while there were initial policy level concerns about the idea of HIPAA compliance, people often forget that our routine practices were not particularly private. We also found that this was a lot cheaper per person than our current practices. And in the interest of time, I'm going to skip ahead a little bit, but just to say this is data now looking at how this played out in the COVID era. And interestingly, despite all the disruptions to TB care and the care that many of us have had in clinics, reduced staffing, the one thing that did not happen was any change in adherence, in part because we in Baltimore, this is from the Baltimore City Clinic, we pivoted very quickly to from in-person DOT to video DOT. And what we found is that we actually improved our overall verification of treatment adherence when using this kind of technology. I do want to just acknowledge that video is one example of how we can document adherence, but there are lower touch technologies as well, ranging from SMS-based technologies to digital pillboxes, all of which offer different levels of verification, but again, offer a menu of options for the purpose of meeting your patients at where they are and for their specific needs. I'd be a little bit remiss in 2022 to not also mention innovation in terms of actual treatments. And I won't go into this in any detail, but just to say that I think in the next year, you're going to be hearing more and more about new treatment regimens for drug-sensitive TB that are shorter than our conventional therapies. So we, for the first time, have regimens that get below 4 to 6 months of treatment. We also have shorter course treatments for drug-resistant TB. I see that I'm close to time, so I'm going to end by talking a little bit about how we can also use innovation to inform our approaches to populations and communities. And this is where mathematical modeling can help us in our policy development. And I think people are much more cognizant of this in the COVID era, where there have been lots of different menus of interventions to curb the COVID pandemic. But this kind of approach has been used for TB care as well. And some of the mathematical models have been used to inform us and identify that just focusing on active TB alone is not going to be enough. We can't get to TB elimination until we focus on latent TB. And this is a study that we did in conjunction with the CDC at 15 health departments across the country as part of a CDC consortium. And the bottom line is that even after diagnosing latent TB, a relatively small portion of patients actually gets treated. And the CDC has recently put forth a really neat little tool that's an interactive tool that any policymaker and health department can be used to actually show what would happen if you were to actually improve that latent TB treatment in your community and look at the projected impact. And I'll say again, this is I'm trying to give you a sense of this as an approach to policymaking. And this can be applied to lots of different diseases. We've done something similar for HIV because there are things like pre-exposure prophylaxis, improved treatments. And this is a tool, again, available freely online. And it allows you to actually, and it's a model that's calibrated to every single local jurisdiction in the entire country. And it allows you to look at what would happen if I improved HIV diagnosis in very specific subgroups, and it'll show you what to expect in your own community so that policymakers can make more informed decisions. But as we talk about prevention, I just want to come back to the idea that we need to support physicians as well. Here you see the clinical recommendations for latent TB care and diagnosis and treatment, which is in some ways a relatively straightforward disease condition. Nonetheless, the recommendations are over 100 patients long. And very often, I can say as a consultant that we get all kinds of questions related to latent TB care, ranging from who should I treat? What do I do with these different indeterminate results? How do I work up a person after a positive result? What do I do when I have discordant test results? And to that extent, I want to highlight a collaboration with Rutgers Global TB Institute, where we've been trying to build interactive decision support tools to help people navigate those specific treatment guidelines. And this makes usage of very simple user interfaces that tries to simplify the guidelines and really walk you through the decision-making process as you would approach a patient at the point of care. Again, the idea to democratize knowledge and help clinicians make the best treatment decisions, even if you're not a TB expert. And this is just screenshots from this specific tool. And the idea is to try to really help clinicians make better decisions. But of course, at some point, you may not get to a point where this kind of automated support is not enough. So I want to also highlight another innovation in the adoption of technology also by the Rutgers Global TB Institute, which is an electronic TB consultation platform. And this is a tool that we created in conjunction with GTBI called ID Crowd. And it allows regional clinicians to basically ask the expert. And this is just screenshots, and it makes it really easy to ask the experts any manner of TB questions and get expert level input, and it goes straight to your email and really facilitates the process rather than having to rely on calling a hotline, calling a consult, and things like that. So with that, I'm just going to end by saying that there's lots of new developments in TB care, but the idea here is that we need to really focus on thinking outside the box and thinking about really critically about how can we do things newly? How can we do things differently and not be stagnant in our routine approaches, which particularly in the TB world, I think change comes slowly. But I think the idea for this particular talk that I hope you'll come away with is that we shouldn't be afraid of change. Not every change will be positive, but hopefully it can lead to better patient-centered care. Thanks so much.
Dr. Shah, thank you very much. Dr. Clapples here, Chair of the Department. I want to thank you for this really interesting talk where you spanned across multiple interesting domains, starting with the Urine LAM testing and what that has done for TB diagnosis and its future, the decision support technology, both for HIV and now for TB, and the issues around how to improve treatment with using technology to supplant perhaps, or certainly have another alternative when you talk about directly observed therapies, which have implications for many things. So thank you for all that. We are nearly just at time, but maybe I can ask Dr. Lardisabel any comments. I want to thank Dr. Lardisabel for the invitation for you today. And if Dr. Lardisabel, any comments around some of the things that have been mentioned by Dr. Shah, we would certainly welcome that.
Certainly. I think Dr. Shah just underlined the importance of looking at available technology to innovate the way we treat a very old disease. I think this is the only way we can accelerate our progress forward towards TB elimination, and actually duplicates those aims towards improving patient-centered care using technology. Dr. Shah and GTBI has worked on various projects, and we thank him for the skills and the ideas he has shared with us through the years. So thank you for a great talk, Dr. Shah.
Thanks so much.
Yep.
So I think with that, I want to thanks Dr. Lardisabel, and I want to thank Dr. Shah again for a really great talk. I want to thank everybody for joining. We had over 125 people who joined us this morning. I hope everybody enjoyed it as much as we did over here, and I want to wish everybody a great rest of the day. Thanks very much again.
Thank you.
Thanks again.